Keezer and I are going to chair this session, and we have 10 speakers today. There is one more talk added at the end of the list. And can I request all speakers to please stick to time? Can I now ask Dr. Sotiris Prapas to come and give the first talk? Sotiris Prapas is one of the world leaders in off-pump surgery and arterial revascularization, and he's going to speak on strategies to deploy arterial conduits.
Thank you, dear Vipin, dear Chairman, dear colleagues. I'm going to present different configurations in order to complete the revascularization using mainly arterial grafts. But who is going to open the presentation?
Yeah.
I'm coming from Athens, Henri Dunant Hospital. Next. Doesn't work. Okay, this is the first cupboard from Favaloro. After that, the classical venous grafting started, but Green proven that mammary can be as a graft on the LAD, and Loop in a historical study proven that this is superior to saphenous vein graft due to continuous internal mammary lamina in mammaries and no continuous in the other vessels. And later on, because of the increased production of anti-inflammatory and vasoactive molecular, particularly nitric oxide. And after that, this configuration prevailed, lima to LAD and vein grafts to the other ones. Bilateral limas since 1974, and in this also historical study, little proven that two limas are better than one. That proven from other studies as well around the world. And recently, BIMA is associating with significant reduction in long-term mortality, even in low injection fraction cases or in older patients. How we can use the IMAS? Initially, they started to use it as a free graft towards to LCA or obtuse marginal, and Tatoulis found some difference at the beginning between the use, but later on, with bigger numbers, the outcomes were similar. And in our days, we have to follow three ways: lima to LAD or obtuse marginal, and this configuration, the T or Y graft. Tatoulis found that lima or rima to LAD has similar outcome, the same by other authors, and the only thing was that the target or the proximal stenosis affected the outcomes of IMAS, as Sabik as well proven. Rita or Lita to other non-LAD targets had inferior outcomes and long-term results. Also the proximal stenosis proven difference in the outcomes. Lita and Rita to circumflex a little bit lower outcome. Anyway, the most effective therapy today is still underutilized in USA, in Australia, in Europe, in Japan more percentage, and in Syntaxtan only 27%. But except the isolated use of IMAS, we use them as a sequential grafts since 1991. But there is an Achilles here, the flow competition, and therefore the native coronary artery stenosis should be more than 90% in order to perform sequential anastomosis. The suggestions are you have to do small arteriotomies to avoid the Seagull phenomenon, the wind angles, and doing the sequentials, the final anastomosis on the vessel with the greatest stenosis will be the choice. About the configurations, T or Y grafts, we have to say that there are advantages in some things. For example, using isolated the IMAs, it's IMA used in situ, the RIMA does not cross the midline, and LIMA is going to LED, the best target. On the other hand, the Y graft has a complete myocardial vascularization. RIMA doesn't cross the midline, and there is no need for completely harvest of the RIMA. But the main disadvantages for in situ use is that we can graft only medial targets, and if we have to go distally, we have to use the muscular part of the mammary, which is not the best. For the Y graft, the main disadvantage is the risk of competitive flow and kinking and some other disadvantages. But as you can see here, the long-term comparison prove similar or even better outcomes than the isolated use. The skeletonization of the IMAs is very important because in this way we save the circuit, the arterial circulation around the mammaries, and this affects the external vascularization. And here there is a huge analysis. Does skeletonization cause arterial injury? No. Affect the patency? No. Affect flow? Yes. It's better intraoperative flow with skeletonization of the mammaries. And in this way, the mammaries are longer and is associated with lower sternal wound complications. Here are the risk factors. Female sex, diabetes mellitus, and beta use, especially when it's pedicle. About radial and GIA as third arterial conduits, GIA started at 1987. There are a few analyses about outcomes. Suzuki proven 90.2 after 8 years, but there are not randomized trials, and today the gastroepiploic artery is still limited in expert institutions. The reuse of radial, which started in 1971 by Alain Carpentier and reused by Akar, increases the use, as you can see here, the radial increasing and the venous grafting decreasing. Here is a huge series from Tatoulis, which has the best experience in the world. He used it as an isolated array graft, 82%, as a Y array graft, or as a Y graft to Lima. And in some cases put it on the descending aorta to reach the lateral wall during the reoperations. Riemann compared to RA, similar operative mortality, superior long-term survival favors RIMA, freedom from repeated vascularization favors RIMA, similar incidence of sternal wound complication in skeletonized. The use of RA should be strongly considered in diabetics undergoing coronary bypass surgery, especially with high-grade target vessel stenosis. The use of radial, you have to take care that RA should be grafted to target vessel with high-grade lesions and is advantageous in diabetes mellitus patients. Is there any place for saphenous vein grafts? As you can see here, venous grafts are not affected by the proximal stenosis, but affected by the site and the size of the target vessels. And Wang found that saphenous vein grafts composite to Lima has similar outcomes in 5 years, but beware about the kinking here. You have to do always Y anastomosis, non-T grafts. And that's due to the preservation of the intact vasa vasorum. And there is also a huge study by Kim, who proved the same outcome in 4 years using the non-touch saphenous vein grafts as a Y graft on Lima. The suggestions, saphenous grafts recommended to bypass the RCA with less than a critical stenosis. Still perform well in the right environment, is preferring conduits for coverage along with left IMA, especially in this technique. Total arterial vascularization is the holy grail of the cavages, and there are superior outcomes in many studies, and Rambaud proven that in this way you can prevent more than 10,000 deaths annually and add more than 64,000 person years of life over the course of 10 years. Should be a routine, the suggestion. The choice of conduits, free RIMA is equal to RA, as proven in many studies. BIMA as Y, it's better than Lima and RA as Y. The same for T grafts. And here there is a comparison of 4 strategies: Y or in situ Lima-Rima with saphenous grafts, SIMA with RA and SVG, SIMA plus SVGs. The worst outcomes was for SIMA and SVGs. That means we have to use at least 2 arterial grafts. And here by Gaudino, there are some suggestions. If there is a major risk factor for postoperative mediastinitis, we have use, if the target stenosis is high in the inferior and lateral wall, an arterial graft, or a saphenous one if the stenosis is moderate. But if the stenosis is lower than 70%, only ITA or saphenous vein grafts. And if there is a great possibility for mediastinitis, we have to use only RA or SVGs to the inferior lateral wall. It's very important, the aortic coronary surgery, because you can see here how reduces the possibility of stroke. Even if we use some devices to do the proximal anastomosis, it's much better to use totally aortic technique. Our aortic method is the P circuit. P graft is consisted by arterial grafts, both mammaries or radial, and we create a secondary circuit connected to the diseased one. For left-sided, we use bifurcations or trifurcation. We use sequential grafting. For the right side, we extend the proximal RIMA or the total RIMA with radial or distal Lima. These are the arrangements, the in situ arrangement, the cross arrangement. Here is the long Y graft. We can reach all the targets with both mammaries, sequential use. Here is a Greek lambda graft. We use the half free rim to reach the lateral wall and the other half one to extend the lemma to reach the inferior wall. And here is the psi graft. In case with very small targets, we create a bridge between the targets and we lead the flow of the other mammary to it. Here you can see 2.8 distal anastomosis, 2.5 arterial. And postoperative complications, few and very low. The primary endpoints, 1.1 mortality, 0.40 CVA, 0.26 acute myocardial infarction. And the variables after a stepwise logistic regression for postoperative CVA, diabetes, and mainly peripheral vascular disease, especially carotid disease. And here is the expected and the observed frequency of stroke, much better than even PCI. And here I'm going to close presenting the state-of-the-art by Pascas. The recommendation is LAD with EMA, second arterial conduits always, beta when a risk of sternal wound complication acceptable, skeletonization of betas, severe stenosis for use of array, not include an age threshold for arterial vascularization, beware native competitive flow patterns and precise anastomotic techniques. And from our side, the P-circuit is a method which can be safely applied in almost all coronary cases to successfully perform an aortic myocardial vascularization. The frequency of stroke is threefold lower than the expected one, reducing more and more the prevalence of this catastrophic complication. Thank you very much.
Thank you, Sotiris. Are there any questions from the audience? So we have another talk on arterial grafts. Thank you, Sotiris. Okay. Can I now introduce Teresa Kaiser? She's from the Foothills Medical Center, Canada. She's also one of the top proponents of arterial grafting in the world. She's also known for her work on TTFM. But today we are going to listen to her talking about the arterial bypass, a graft for all reasons.
Good morning, everyone. It's wonderful to be here in Kazakhstan again. May I please have my slides? Okay. We're going to talk about total arterial grafting, and it's not just about the graft. These are my disclosures. My arterial grafting experience: for the first 15 years of my practice, I performed 30% BEMA, and the last 14 years, 74% BEMA. In 1442 patients, 4198 bypasses, 98% arterial grafts, and 83 veins, or 2%. Let's talk about IMA grafts and vein grafts. Why are vein grafts not as good? They were never meant to be arteries. Some last 30 years, but most don't. Common sense. The blood pressure in your leg veins is 25 to 35 millimeters mercury. The blood pressure in arteries is 120/80. Why are IMA grafts so good? Because God made them that way. They are a drug-eluting conduit. They secrete prostacyclins and nitric oxide. They're composed mainly of elastic fibers. They have nutrition from the lumen and a rich lymphatic drainage. They auto-regulate in response to demand. And location, location, location. They are right next to the heart. Why do surgeons not use bilateral internal mammary arteries? It takes longer, but we are no longer barber surgeons, so we don't need to be so quick. There is reluctance to believe in the superiority of a BEMA over SEMA. There are technical challenges to two IMAs. There is the perceived conduit coronary flow mismatch, and there is the risk of sternal wound infection. Vein graft patency has not changed in 30 years. using Dr. Fitzgibbon's seminal paper from 1996 and comparing with 3 more recent papers. Early patency of vein grafts, 12% are included with Fitzgibbon, and in Kim's paper of 2010, 11.8% are included. At 1 year, Fitzgibbon found 19% included. McGee in the Prevent 4 trial found 25.5% included. Late, more than 15 years, Fitzgibbon found 50% included, and Tatoulis in 2011 found 50.7% included. Here's a 25-year-old vein graft to the LAD. Well, it's 25 years. Can I have the next movie, please? Can somebody play the next movie? I don't have controls. Hello, anybody out there?
Anatoly, can we click on the second video, please?
Thank you. This is a vein graft to a diagonal marginal. Keep it going. At 6 years, and look, the distal anastomosis is fine, but the vein graft is not. Excuse me. Here is, you've heard of patient prosthesis mismatch. What about conduit coronary mismatch? The movie on the left is a vein to a marginal artery. Please click on the next video. Thank you. And this is a vein to the LAD. What about when? What is the age cutoff for BIMA? Mohammadi, a colleague of mine in Eastern Canada in 2008, presented at the EX meeting in Geneva 12,231 patients with 11.3% BIMA, 13 years follow-up, 13 years span, 5.7 years follow-up. When he presented the paper at EX, he said the cutoff age was 65 years, but when the paper came out in EJCTS, it was 60 years old. I went ballistic. I went back to our unit and I said, we have to look at our numbers. So we reviewed 5,601 CABG patients over, again, 13 years. We had 19% BIMA, mean follow-up was similar, 7.1 years, and we found a not significant, but a definite trend to improvement of BIMA survival up to 70 years. This is the spline diagram, spline analysis. The axis on the left is the hazard ratio of the BIMA versus SEMA over time. The solid line is the hazard ratio itself. The dotted lines are the 95% confidence intervals, and where the line intersects, the one line is exactly 70 years. So what this says is that BIMA is beneficial up to the age of 70, not sure after. It's analogous to what is written on our milk cartons. It says the milk is best before. It does not say it is bad after. This paper has been referenced in 2 guidelines, both sides of the Atlantic, and the general consensus now is that BIMA has an age survival of up to the age of 70. Every category now is written, is documented with BIMA survival. Since the first paper by Kouchoukas in 1990 warning us of the dangers of bilateral mammary in diabetics. Since that time, there have been at least 10 papers come out saying it is safe to do bilateral mammary in diabetics. There's bilateral mammary in elderly, BIMA in emergency urgent CABG, routine use by Pevney in the Tel Aviv group. Dialysis patients, BIMA reduced ejection fraction, and BIMA and women. So in early days in my training, we never did BIMA in ejection fraction low, endarterectomies, any of these things, but now it is commonplace. Excuse me. When not to use IMAs, true cardiogenic shock, no need, there's already NEMA from another OR, unusable, some memories are fragile and self-destructing, and obese female diabetics, one subgroup of diabetics. Let's look at this. In a study from our group, 1,001 CABG procedures, there were 16 deep sternal wound infection, which looks pretty good, 1.5%. But when you find out that they all occurred in the first 532 patients, this was an incidence of 3% versus 0 in the last group. 6 of these 16 deep sternal wound infections were in obese female diabetics, which was 38%. This is a diagram showing every permutation and combination of gender, obesity, and diabetes, and you can see one group stands out, the obese women diabetics. Their infection rate was 21.4%, which was 10-fold greater than the 2% for all the other subgroups. What about ensuring work accuracy? You can assess your bypass function in the operating room. In a study from 2010, we looked at 1,000 arterial grafts. I'd been using this machine for 3 years and didn't really think very much of it until I reviewed my results. We divided the group into 2 groups, PI less than 5, which are good grafts, and PI greater than 5, which are possibly suboptimal grafts. And you'll see here the MACE and the operative mortality were significantly higher in those patients with a PI greater than 5. We did the same comparison for flow and diastolic filling, and they were not predictive of outcome. Here is a bar diagram showing the same thing. The red is the patients with the high PI value for all major adverse cardiac events. All mortality, again significant, and thinking that emergency cases may have played a role, we removed the emergency cases. Still, the operative deaths were more significant in the patients with high PI. This paper is referenced in 3 guidelines, the 2010, 2014 myocardial, and the NICE guidelines in UK. Prevention of deep sternal wound infection. This is the Achilles heel of BEMA grafting for most surgeons. In a study of 1,001 CABG procedures with 74% double mammaries and 34% diabetic patients, you've seen these numbers before, we had added multiple infection prevention measures over many years, but 9 of them had been over the previous 12 years. The rate was 3% for the first 532 patients and then 0 for the last 4.5 years. These are the infection prevention measures. Some of them are easy. Don't use bone wax. Irrigate the subcutaneous tissues. Skeletonization is not easy, but is extremely important in the prevention of infection. I've used the harmonic scalpel since November 23, which may or may not be contributing. Vancomycin paste on the sternum just before approximating the wires is really easy and very important. And our whole group changed to chlorhexidine with alcohol from betadine, and our infection rate dropped to 1/3 of what it was. And various other things were done. This is a diagram showing the infection rate for this paper. The green dots are the infections, and the arrows are the interventions. And you can see where the last infection stopped. And since this paper, since August 2008, when the last infection occurred in this paper, there has been 1 equivocal infection in 916 CABGs till August 2017, a rate of 0.11% by just following these simple measures. So in conclusion, the risk of deep sternal wound infection can be reduced to close to 0. It's never 0. As long as you're operating, there's a potential. As soon as you say you have 0, God's going to get you. Infection is usually caused by a transgression of several barriers to infection. Conversely, the prevention of infection may be caused by adding multiple layers of protection. Avoid BEMA. It is prudent to do this in 1 subgroup of diabetics, obese women, which is only 13% of diabetics in this study. The majority of diabetics can have BEMA grafting without increased risk of deep sternal wound infection. Completeness of revascularization. You've all heard that if you don't completely revascularize your patients don't do as well. Well, if you use arterial graft, you don't need to worry so much. We looked at 1,000 patients and had 140 or 14% without incomplete revascularization. And operative mortality, there was no difference after adjusting for your score. At midterm follow-up, 34 months, for patients less than 80, the hazard ratio was 1.2, no difference. And there was a strange age dichotomy. Patients greater than 80, but there were only 53, had an increased hazard ratio of 5.7. The bottom line, use of arterial grafts mitigates the effect of incomplete revascularization on survival for patients under the 80 years of age. Is this due to the increased attrition rate of saphenous vein grafts? We've just seen how a lot of them go down at early and 1 year. You can decrease your unnecessary operative time with the harmonic scalpel. As Dr. Prepa said, the skeletonization is mandatory for length, sequential grafting, and deep sternal wound infection prevention. There are 2 methods, clip, cut, and cautery typizide dissector, and the harmonic device. The harmonic hook blade used in 9 to 65 patients at this point is faster. It damages the IMA less. The MACE is the same as the non-harmonic patients, and lima patency at 5 years was 96%. Here's a little mini movie showing the use of the harmonic scalpel. You use it like a paintbrush. You paint the mammary. Here I'm I call it the double prong technique. I put 2 prongs either side of the branch, and I sit on it with the harmonic. The end is 2 millimeters. I have a harmonic blade with me if somebody wants to see it afterwards. It's small, easy to use, and you're sweeping the tissues very carefully. The advantages are there are no clips. The smoke you see here is not smoke, it's steam, so there are no airborne particles to inhale. And what you have left is a skeletonized mammary, no clips, and if you look at the undersurface of the chest wall where you were, there's no char, it looks like you were not there, and there's no char or infection potential material. Just a couple of words about the gastroepiploic artery. It was introduced in '87 independently at 2 sites. It can be used as in situ or free. Although the body abdominal cavity is entered, complications are minimal. I've used 5 in my life, okay, just to let you know. Patency compares favorably with the radial artery. Use is more popular than Asia than anywhere else. It does provide an all-arterial nerve touch aortic CABG when you use it with BIMA, and free grafting provides better inflow. It is subjective to competitive flow and vasospasm like the radial, and Nakajima also found that the GEA was unsuitable for moderate stenosis of the right and the circumflex. The radial artery. As Dr. Prappas said, it was first used by Carpentier, and then they abandoned it because it was found to have worse patency than vein grafts, and then it was rediscovered by Akar, and it prompted revitalization, and he reported results of 104 patients with 93.5% patency. They did 3 changes. They harvested it as a pedicle with no-touch technique. They used pharmacologic dilatation instead of mechanical, and vasodilators post-op. Advantages to the IMA: it's longer, it's easier to use. It's like using a vein, for goodness sakes. It's no contraindication to obese or diabetics because you're on the arm. And compared to vein, it can be used in either direction, and it certainly has increased longevity over a vein. Disadvantages: you have the forearm, you have the sensory disturbance. Sometimes you can endoscopically harvest, but it may not be as long. Spasm propensity is a problem, or it can be a problem. You can reduce this excuse me, by oral IV vasodilators, less traumatic harvest, injecting the pedicle with a papaverine solution, and I use papaverine 65 and normal saline, or excuse me, if it is really unrelenting spasm, the intra-aortic balloon pump takes care of that. So how do I prevent radial artery spasm? This is a little mini movie. I take the papaverine solution I showed you, and I inject the pedicle. I'm not injecting the radial, and it blows up like a little balloon. And I use 10 cc's on every mammary to make it consistent. I flip it over, and then I inject the other side. And I have, since I've been using this since July 2012, I have yet to see a serious spasm of the radial artery. Where to put arterial grafts? Well, you do need a major stenosis, 70 to 90, depending who you read or believe. The radial artery is better than the vein, so if you're using with vein, put it on the second most important artery after the lima to LAD. The radial artery at this point in time is thought not to be as good as the IMA, so if you're using with 2 IMA grafts, put it on the least important artery. However, I have been saved by the radial when the internal mammary fell to bits, and vice versa. The coronary anastomosis. This is just how I do a coronary anastomosis for the students that are in the audience. It's like sewing a sleeve on a coat or a dress. The puffed part is your mammary, the sleeve is your coronary artery. In order to get that cobra head, you have to have more material on the top, and this is how you do it. This is just the Kuiper stitch. After I'd use several stitches, 4 to 5, flip it over, and then I start sewing on the surgeon's side to about 1/3 away from the toe, complete on the other side to about 1/3 from the toe, and then I cut off the edge that has been held by the forceps, and I use a flat-topped roof, not a pointed roof. And so you end up with an anastomosis that looks like a cobra head. And note, there are more sutures around the toe and the heel. This is very key. This is a little mini movie. There's another aspect of that I like to do. I don't turn my body or the arm. I pivot my needle on my driver 360 degrees. So it is always perfectly positioned. Where I go to put my needle in, it is exactly where I want it to be, 1 millimeter at a time. I've found this exceptionally useful when you're trying to do off pump and you've got this much space between the chest wall and the artery. How to get the REMA to the circumflex system? You need to, as the crow flies, via a hole in the pericardium near the superior vena cava, through the transverse sinus to the circumflex in the back of the heart. No matter where it is, I can manage this to reach 91% of the time. I also use this same hole for a rima going to a right coronary artery or a posterolateral branch. How do you get the rima to the PDA? You use a hole near the inferior vena cava. And this means that the mammary is extrapericardial. It makes the turn point at the pericardium, so it lies true onto the arc right on the PDA. And this is possible 89% of the time. Here is a video of going through the transverse sinus to the marginal in the back. Please, can I have the second movie? Hello, audiovisual, thank you. And here it is, you can see the turn point is down by the SVC. It is not right at the heel where it can block off. This is really the best. I found this out from a surgeon in Switzerland many, many years ago. Just a word about if you damage a mammary artery at the top end, don't throw it out, use it. Here's a patient, I did that, I damaged the lima at the top end, so I attached the rima through the transverse sinus to the marginal artery, and then the lima to the rima to the LAD. Please, can I have the second movie? Thank you. This is easier to see here. There's the rima coming down to the marginal and the lima attached to the LAD. This patient is now 10 years post-op. This angiography was done to 7 years. He is perfectly fine. Summary points. It's my favorite picture of Kazakhstan. In 2013, Bruce Lytle said, cardiac surgeons are greatly incentivized to function extremely well in regard to short-term outcomes, but do not practice the same scrutiny regarding long-term outcomes. And the only advantage of complex ITA grafting operation are improved long-term outcomes. Blood flows every which way. You can connect anything to anything and it will work, as long as the connection is not technically flawed. Arterial grafting can be used on all patient subgroups with safety and attention to detail. Successful arterial grafting depends not only on the anastomosis, but the techniques used, prevention of infection and intraoperative assessment. BIMA is possibly the most important thing a surgeon can do for CABG patients. An extra 20 minutes for an extra 20 years. Here is a lima, sequential lima to a diagonal LAD. To the right, please. Movie to the right, thank you. This is a lima to a Y with itself, to the LAD and the marginal. So one lima is supplying the whole of the heart. A left lower, please. Here's left lower movie, please. Hello, audiovisual. Left lower movie, please. Thank you. Rima going through another one through the transverse sinus to the marginal. And the last movie, please, audiovisual. And this is another rima to PDA coming extrapericardial, lying true along for the PDA graft. Last, I'm just going to end with a quote from my youngest patient, 29 years. She was 14 weeks pregnant at the time of her surgery, and she's standing here with her son, and she said to me in an email, "Doctors always question the scar on my wrist and are astounded to hear that you use arteries in my heart. It makes only sense." Thank you.
Are there any questions from the audience? Use the mic, please.
Well, first of all, I'd like to congratulate Teresa and Sotirio. Very nice presentation, both. Only anecdotal. It's interesting the way you take the mammary, because I have the opportunity to review some of the Miami patients when I was there, and I learned the way they take the mammary. It's very similar to the harmonic scalpel. I mean, with tissues around it. I never skeletonize the mammary totally. I leave some tissue. And I think this is something to do with the long-term patents that they have. And the other thing is that most of these patients have left internal mammary to LAD and right through the transverse sinus to the cervix. So they don't have connections. So we don't know really if the connection of the mammary will still 20, 40 years or 30 years, how this man. But it's interesting the way, I think it's very important the way you skeletonize the mammary. And the other comment for Sotirio, the contraction of the P, I think have a lot of sense to think in the future to decrease the size of the incision. Probably it's the only way we will be able to learn to perform complete revascularization with lower sternotomy, because it's very difficult to contract the graft. It's very high, so it's difficult. So I think perhaps we need to learn how to contract through the right mammary. His contraction, I use the left mammary alone to the left internal, to the LAD. I don't know, it's something to think. Thank you.
Thank you very much. I totally agree. Those are really excellent techniques, and I hope to employ them. Thank you.
Yeah, we have one more question. Yeah.
One question to you. If you have the situation that the patient have good right coronary artery in the crest before PDA, what the place for your distal anastomosis, PDA or right coronary artery?
What level is the stenosis?
Some more, some in
80, 90?
The bifurcation is good.
Yes, okay, but what is the actual stenosis level of the right coronary artery? Is it 70%, 80%, 90%?
It's you must create anastomosis with right coronary artery. And
Yeah, okay.
what the place of distal anastomosis?
It depends on the level of stenosis. If the level of stenosis is only 70%, I will still go to the PDA, because Joe Savick showed in a paper that all grafts to these branches of the right coronary do not have competitive flow. But if the right coronary artery has a 90% stenosis and the right coronary artery is very soft and beautiful, I make it to the right coronary artery.
Thank you very much.
Okay, any other questions? I have one question for you, Teresa. You said obese diabetic females have a higher incidence of wound infection.
Yes.
What is it about females? Why not males?
I don't know. I think it's their anatomy, I believe. It's just maybe there's more adipose tissue over the sternal area. Sun doesn't shine very easily there. You know, I mean, it's just for men, and it's the BMI level is over 30. It wasn't that high. Like the worst ones were in the BMI 45. But I don't do that now. I try to.
Okay. Okay. Thank you, Teresa. Can I now ask the next presenter, Dr. Chernow, OPCAB as a standard in modern surgery of ischemic heart disease.
Good morning, dear chairmen, dear colleagues. For me, big privilege to be here, and I like to talk about our results in OPCAB surgery in our centers. Next slide, please. We all know that Vasily Kolesov, one of the pioneers of cardiovascular surgery, in February 1964, he performed the first successful coronary artery bypass operation without cardiopulmonary bypass. This angio, our first patient, it was in 1993. His name was Lenin, not leader of October Revolution. He was engineer, 43 years old. This is first my experience in not only OPCAB and cabbage. The patient come to our hospital after 2 cardiac arrest and good treatment after angio, and in this time we have not Hadlan machine in our hospital, and we decided to perform him cabbage on beating heart. One venous graft to LAD. The situation is okay. Now patient is living, good condition. Vein graft is potential as well, venous graft. And this is first experience, our experience on beating heart. Cabbage remains the most common procedure in cardiac surgery in the world. CPB is not physiological procedure. Sometimes I asked our perfusionist, what is the main question on your meeting for perfusionist? What is the main questions? They ask me that the main question is what can we do CPB is more safely. But now CPB is not physiological procedure. Equivalent outcomes of CABG and OPCAP in experienced surgeons. Advantage of pump CABG are particularly evident for higher risk patients, low left ventricle ejection fraction, elderly patients, women, and patients with renal dysfunction. Now interest most surgeons to OPCAP surgery is stable, not very increased. The last year is approximately 300 papers in medicine literature. Coronary surgery in Russia. In this picture we can see conventional CABG and OPCAP CABG, but some tendency to higher patients who have CABG without Hadlan machine, 22%. Now I work in Federal Center in Astrakhan during 10 years. This is a new center. It was founded in 2008. 16 million people living around our centers. 5,000 cardiovascular procedures, including 2,000 open heart operation in adult and about 1,000 CABG. Per year in our center we performed 95% CABG OPCAP. Evolution coronary surgery in Astrakhan Federal Center, you see that in first years we have experience in traditional CABG with cardioplegia, with Hadlan machine, but now we have some surgeons who never seen traditional CABG because all patients going to operation to CABG without Hadlan machine on a beating heart. You can see percent of conventional to traditional CABG enduring operation OPCAP. As you see, in first years it was very high, but now it's less than 1%. It's the same mortality. The aim of this report is to demonstrate our experience of pump coronary artery bypass grafting. During 7 years, we have experienced more than 6,000 cases of CAP. You can see percent of males, the main age, history of myocardial infarction, angina pectoris 3-4 class, injection fraction, and diabetes mellitus. Number of distal anastomosis and index of revascularization. You can see approximately 3. Not big, but not so small. We use the next conduits for CABG, RITA, radiology. And the first time we used very often, but after some days after spasm of radiology, we stop use radiology, and total revascularization is very small. We try to do more and more from year to year, total arterial revascularization. Endoscopic, we use endoscopic vein harvesting. intracoronary shunt for forming distal anastomosis, sequential technique in distal anastomosis, epiaortic ultrasound, no-touch aorta, intraoperative TTFM, routinely used, and ligation left appendage in patients with atrial fibrillation. You can see epiaortic sonography. Our scrap nose, one of two scrap nose who harvest endoscopic vein graft. They have a practice, and now our scrap nose removed endoscopic vein graft. Proximal anastomosis, we used side clamping, hot string, very often, especially when aortic ascending aorta is calcificate, and no-touch techniques. Intraoperative flow management, every patient after cabbage. And our results, 6,500 cases, conventional 1.7%, perioperative infarct myocardial infarction, bleeding, stroke, deep sternal infection, and hospital mortality 0.7%, and last year 0.2%. Cardiopulmonary bypass is not physiological. Technology of op-cap surgery has excellent result of surgical treatment of coronary artery disease. Advantages of op-cap surgery are particularly evident for central group of patients. We widespread use of op-cap remain the prerogative of the individual centers with high level of experience in such operation. Over time, the op-cap has become a standard technique in coronary surgery in our hospital. Off-pump teamwork allows use to perform op-cap with good results. In our hospital, all surgical patients with isolated CAT are candidates for op-cap procedure. Thank you for your attention, and thank you for my bad English.
Thank you very much, Dr. Chernov, for your excellent results and beautiful presentation. I have a question for you. Since the Ruby coronary and GOP-CABI trials came out saying that there was no difference, I fear that people who are off-pump before are not doing as much off-pump because of these trials. How much off-pump surgery do you think one needs to do to maintain expertise? Only about 6% of patients in my practice have a calcified aorta and need to be done off pump. But if you only do 6%, that's not enough. What would you think would be enough to maintain expertise in op-cap surgery? How many cases, what percentage of cases?
Excuse me, I don't... Just a moment. My friend, help me, please. Thank you. I don't know. I mean that for me, main reason to change strategy not for big cases. You must give a philosophy. Must be philosophy, but change maybe 100, 200, 300 cases. After this, you...
Okay, yes, no, I agree. I'm just wondering if you, an ongoing process, probably I think it should be 50% at least doing off-pump to maintain expertise. Go ahead, Vipin, you have a question?
I must congratulate you on your excellent results. You showed a slide showing 20% of cabbage cases in Russia are performed off pump.
Yes.
So is that from a Russian registry?
Yes.
Is that available online?
We have in Russia 20% now. 20% all cabbage
Okay.
without hard machine op cap.
Okay. So, no, that is excellent. Now, if you have the Russian registry, your mortality is less than 1%. What is the mortality of cabbage in Russia as a whole?
I mean, in other hospitals who used these techniques, the same mortality.
No, but in Russia, because you have data on the proportion of cases done off pump, so you must have a Russian registry.
Then approximately about 2.5% mortality.
Okay, thank you very much. Oh, sorry, there's one more question. Rui, make it quick, please.
Yes, I just want to answer what Dr. Teresa asked. Dr. Enio Buffalo, who was one of the first ones to use OPCAP surgery, says that this surgery is not for all patients, and especially not for all doctors to do it. And he started with 50% doing it, and it came down to 21 to 22% of his practical clinical doing OPCAP surgeries.
Okay.
This is after you've done it for many, many years. You can come down to that level. Yes, I agree. Okay, thank you very much.
Thank you very much. I think it's me now.
Okay. Now we're going to hear Vipin talk about technical tips for off-pump cabbage surgery. And Vipin needs no introduction. He's the big man on the campus here.
Okay, thank you very much, Teresa. Can I have my slides, please? We just heard the excellent results that can be achieved with off-pump surgery in experienced hands. And I'm going to describe very briefly some technical maneuvers that we use in our hospital to facilitate off-pump surgery. And there are many experienced surgeons in this room, but for those people who would like to start off-pump surgery, I think these tips would be very useful. There is a wide variation in the uptake of off-pump across the world. In the UK and the USA, only about 10 to 15% of cases are done off-pump, whereas in Japan, as in the country as a whole, 60% cases are done off-pump. And we heard this morning just now that in Russia, about 20% of cases are done off-pump. In the UK, there are about 50 units where cardiac surgery is done, and there are some units which do no off-pump surgery at all, and there are some units which do about 50%. In my unit, we are 6 surgeons, and approximately 50% of our workload is done off-pump. And in my personal experience, more than 95% cases are done off-pump. And are off-pump surgeons technically superior? I don't think so. It's just a question of a few technical tips that you have to know and that you have to execute to be able to perform a successful off-pump operation. Now, what I'm going to do in this talk is to give a few technical tips, and what I would like to stress is that in Edinburgh, we use the whole package. We use all these technical tips to facilitate an operation, and you can't pick and choose because everything depends on every other tip. The incision, we use a long incision going from the suprasternal notch to the zippy sternum. We don't believe in making a smaller incision because anyway you're going to do a sternotomy, so a big incision helps to give us more space. So that this here, you can see the incision is quite long. The retractor that we use, this is the head end of the patient. The photograph has been taken by an anesthetist. So we use the retractor such that the horizontal bar is at the head end. The advantage of this is that this portion of the retractor is at the lower end of the sternum where you need maximum retraction, and that gives us more space, especially when you're harvesting the obtuse marginal and posterior descending arteries. The pericardiotomy is an inverted T-shaped, and the horizontal limbs, we go on the right side, right up to the IVC. Of course, you stay away from the phrenic nerve, and on the left side, we go beyond the apex of the heart. So this wide incision is very important to be able to manipulate the heart easily. The left and right pleura, we open them widely all the time. The advantage again is that we get a lot of space. And these are the photographs that show that this is the left pleura, which has been opened from top to bottom. This is the mammary being harvested. And this photograph shows the horizontal limb of the pericardiotomy going beyond the left apex. We open the right pleura as well, again from top to bottom, and a very important point is that we excise this pleuropericardial fat. This whole fat has to be excised. It gives more space, and it allows us to flip the heart into the right pleural cavity. So the next few slides show the fat being removed, and quite a big chunk of fat comes out. And I described on Friday the Zamwar pericardial fold and the pericardial stitch, and this is the fold again. It runs from the inferior edge of the left inferior pulmonary vein to the superior edge of the left pulmonary vein. And we take a stitch over there. This is the line diagram showing the pericardial fold. This is the visceral pericardium, this is the parietal pericardium, and the fold is formed by the visceral parietal pericardium folding back onto itself and then again traveling back peripherally. Because of the fold and the fibrous pericardium underneath, it becomes quite a tough structure, and when you take a stitch across this fold, there is less chance of damaging the pulmonary vein. In fact, it's very difficult to damage the pulmonary vein. This is the pericardial fold. Is that a video? Yeah. This video shows the pericardial fold being taken across the lower part of the The stitch is being taken across the lower part of the fold. And this stitch is then attached to the drapes on the left side, and it is kept taut by attaching it to the drapes, and a swab is kept in between the stitch and the heart to prevent the stitch from cutting through the muscle. And this, while many years ago I was experimenting with various positions to put the stitch, and of course we know about the Lima stitch, which is kept in the oblique pericardial sinus. And while experimenting with various positions, I came across this fold, and I realized that a stitch taken across the inferior vein is the best way to lift the heart up. And there is minimal hemodynamic instability when you use the stitch in this particular position. And if you can see from this photograph, now that the stitch is taut, you can manipulate the heart anyway. The LAD and diagonal are easily accessible. To access the obtuse marginal, the apex is lifted and is put inside into the right pleural cavity. And because we have opened the cavity, the pleural cavity, and because we have excised the fat in this region, the heart flips in very easily and giving good access to the obtuse marginal arteries. And to access the posterior descending artery, you just lift this heart up towards the head end. And there is minimal hemodynamic instability using these techniques. So a Trendelenburg position is very important when doing the obtuse marginals and the posterior descending arteries. And very quickly, I'll go through some other adjuncts that we use. We use a cell saver. We use the octopus stabilizer. There are many stabilizers available. In our unit, we use the octopus. We always use the shunt, and we use a blower mister. The shunt is important because it provides perfusion to the distal area, but more important than that, it prevents the back wall being taken accidentally. Once the shunt is in the coronary artery, it allows the liberal use of CO2 in the blower mister. And every now and then, in less than 1%, perhaps in less than 1% cases, there is going to be a problem. And if the heart goes into VF or you need to convert in an emergency, if the shunt is in place, you can place the heart down and cannulate and go on bypass. if the shunt is not there, it becomes a double problem because the artery keeps on bleeding as well. A shunt shuffle technique is a technique that we use to insert the shunt. The shunt is inserted into one end of the coronary artery, pushed back in, and when the other tip is in the arteriotomy, you push it into the other side. And that's one of the techniques that we use. We always use a smaller size shunt compared to the size of the artery. That it's because once the shunt is in place, the artery almost always goes into a little bit of spasm, and then there is no space for the needle between the shunt and the coronary artery. So we would recommend a slightly smaller size shunt. We use the Medtronic blower mister. We use CO2 about 2 to 4 liters per minute. We use saline, which is at a pressure of about 150 millimeters of mercury, and this produces a fine mist. And I think in the interest of time, I'm going to stop my talk here. The order of grafting is not particularly important. We always do the lima to the LAD first, or we use technical considerations. Sometimes if there's a problem, you have to use the collateralized vessel first rather than the collateralizing vessel. However, that is very, very rare. So we would always follow a technique that makes it technically easier for us to do the operation. Okay, Teresa, I'm going to stop here just because we have an extra talk as well at the end of the session.
Okay, Vipin, thank you very much for a beautiful overview. Are there any questions at all for Dr. Benetti?
Only a comment that is important. I'd like to congratulate Vipin because, you know, we described this technique using the pericardium, but he described for the first time this reflection. This is very interesting because we all use this area of the pericardium that is thicker, but we didn't know that the anatomy of the pericardium is half a reflection there. So he described this anatomy position, and so congratulations.
Yes, it is very definitely. Congratulations. And it is tough, and it cannot damage anything. The lima stitch, you can get the esophagus, you can get the aorta. You can't do that with this stitch. So it's not only practical, it's safe. Thank you, Vipin.
Thank you.
Okay, now we're going to go on to, just a minute, where am I? Bilateral mammary artery bypass grafting, extent of use and focus on sternal wound infection by Dr. Justine Revaux. Justine, so excuse me, Revaux. My French is getting better.
Okay. Good morning, everybody. My name is Justine Revaux from Belgium. And first of all, I would like to thank you for giving me the opportunity to speak today at this Congress. It's a great opportunity for me, so thank you for all. And I would like to present to you our work about bilateral internal mammary artery bypass grafting and sternal wound infection in high-risk population. We have no conflict of interest. Okay. As we all know, bilateral internal mammary artery are underused in coronary artery bypass grafting nowadays all around the world, especially in elderly patients, diabetic and obese patients, owing to the high incidence of sternal wound infection, sternal instability, and reintervention for bleeding in this kind of high-risk population. That's why we decided to make a single-center retrospective observational study in our center, Grand Hôpital of Charleroi-Gilly in Belgium. We include 319 patients undergoing coronary artery bypass grafting from December 2011 to December 2015. All patients received a BMA grafting, and we analyzed 3 main outcome measures. That's to say sternal wound infection, sternal instability, and reintervention for bleeding. Mammary harvesting was always made in a non-skeletonized fashion because with an electric scalpel, because we consider it as more technical challenge and a more a method with a longer operating time that can promote sternal wound infection. So combination and number of anastomosis was selected according to the coronary findings made before the intervention. We used 15 radial grafts all are vested by stereoscopy. 44 additional venous saphenous grafts were used, and the right mammary artery was used as free graft in 71% of my series, and as pediculate graft in 91 patients. About the closure of the chest wall, I wanted to talk about the sternotomy closure system from A&I Medical Corporation. That's to say 3 double wire and 3 single wire. As you can look, the wire were passed through the sternum approximately 1 to 1.5 centimeter lateral to the midline through intercostal spacings. We always use double wires because they are able to reduce about 8 times more than single wire the shear stress. And by reducing shear stress into the bone, we can avoid empty spaces that can promote or lead to sternal wound infection. If I can pass to the video, can you let the video move, please?
Anatoly, can we have the video, please?
Can you? Yes.
Yeah, thank you.
Thank you very much. So, as you can see, a rotary movement of the wrist is used along with a vertical pull on the wires to twist tightly the wires until the 2 bone edges were close to one another. Your elbow has not to move when you are making this, and it's easier to make and to reproduce. The double sternal wire is always placed with the double sternal wire twister, as you can see here. Here you can see a postoperative X-ray of a patient that was operated, and the position of the double wire and the single wire depends on the patient anatomy, obviously. Making this work, we wanted also to insist on the difference between sternal wound infection and sternal instability, because if sternal instability is a clear factor identified as a risk factor for sternal wound infection, it can be also a problem in itself. And that's why we decided to define sternal instability as a separation of the sternum at the midline due to bony fracture or disruption of the wire. When we took the criteria from the Center for Disease Control and Prevention to define sternal wound infection, that's to say an organism isolated from culture of mediastinal tissue or fluid, or evidence of mediastinal due operation, or a combination with chest pain, sternal instability, fever over than 38 degrees, and purine drainage from the mediastinum with an isolated organism in the blood culture or in the culture or in the mediastinal area. That's are the statistical analysis we made to obtain our result, and the p-value under 0.5 was always considered significant. That are our global results. The global mortality rate was 6%. 19 patients died during the study. The mean Euro score was 4.9, and we have a global incidence of sternal wound infection of 4%. 14 patients presented a sternal wound infection. When we analyzed this result in the subgroup we made, you can see that in elderly people, so people over 75 years, you can see that sternal wound infection, sternal instability was lower in this group, while in the younger people, sternal instability, sternal wound infection was higher. That's not the case for reintervention for bleeding. Reintervention for bleeding was more present in the oldest population. In the diabetic population, we can see that the incidence of sternal wound infection was higher than in the non-diabetic patients. This result seems to confirm the current literature in this file. But when we divided the group of diabetic patients into diabetic patients treated by insulin or not, we can see that we have a lower incidence of sternal wound infection in the subgroup diabetic treated by insulin, while we have absolutely no sternal instability or intervention for bleeding in this group. So confronting to the previous slide that I showed, it seemed not to confirm the current literature in this field. And that's the same from obese patients. We define obese patient with a BMI over than 30, and standard wound infection, standard instability, and intervention for bleeding was all lower in the obese population, while in the population of patients with a BMI under 30, the standard wound infection, the standard immunity, and reintervention for bleeding was always higher. Finally, the only statistical significant result that we found is that reintervention for bleeding is clearly a risk factor identified for death, with a p-value calculated to 0.004. As a conclusion, we want to say that in our center, obesity, age, and diabetes, treated by insulin or not, do not seem to be a risk factor for developing standard wound infection, standard instability, or reintervention for bleeding in patients receiving coronary artery bypass grafting using bilateral internal mammary artery. But obviously, mortality is higher in patients requiring reintervention for bleeding. Nevertheless, we agree and we promote that every case of standard wound infection has to be reviewed in a multidisciplinary team, and the main cause has to be carrier for the safety of the patient. Spasibo, and thank you for your attention.
Can you go back one slide, please, the conclusions?
Yes, for sure.
Any questions from the audience? I would like you to exercise a bit of caution with these conclusions.
Yes.
Your study is it's not randomized, but we give that apart. You've only studied patients who've had bilateral memories. You had 319 patients.
Yes.
So
it's a little sorry. Yes.
But what percentage of your patients had bilateral memories? What was your total workload during that time?
I'm sorry, I don't understand.
No, you did 319 patients with bilateral memories.
Yes.
But during the same time period in your hospital, how many cabbage operations were performed?
In the same time, how many cabbage? Maybe 700.
Yeah, so, I mean, that is very important. So you have chosen your patients. You have chosen.
It's clear that retrospective study is always
Yes.
That can be BA.
Yeah.
It's clear that it's a retrospective observational study, so there is a selection of patients.
Yes.
It's clear. It's clear that the power of the study that can be compared with a larger series or with prospective study or with other kind of study. I don't pretend to present a big series of cases, but I think it was important to say that in our protocol with the patient that we choose, maybe it's possible to have an acceptable incidence of standard wound infection, because 40% is not so bad when you look in the literature. But obviously in the literature, there is no study with the same design as us.
Okay, thank you very much. Any other questions from the audience?
Yeah, well, congratulations, very interesting question. You think this is because of the way you close the sternum?
We think that the standard closures is very important according to us, because when you look, the state of the patient, if you close the sternum always with the same protocol, I think it would be possible to have a lower risk of incidence of standard wound infection. That's why I wanted to insist on the standard closure in my presentation.
Okay, thank you.
Thank you. Okay, sorry.
First off, excellent presentation. Let me congratulate you on that. And my question is,
Thank you.
have you ever thought about comparing your results versus the platelet-rich plasma closure of the sternal wound Of course, you know this splendid series of excellent results, no infection, even with the diabetes, with obesity and stuff like that. Did you do any survey of literature just to compare your results against the plasma, platelet-rich plasma?
With? I don't understand what you mean.
Platelet-rich
Yes, okay.
plasma.
No,
so
we don't.
No,
we don't analyze this.
Just to find out the superiority or inferiority of the two methods. No.
No. We don't.
Okay.
We don't make this difference between.
Okay. Thank you.
In my study.
Yeah. Okay. Thank you very much.
Thank you.
Now we will hear from Professor Pavel Mialek on differential approach to prevent stroke during CABG procedure. Mialek? Dr. Mialek? Is he here? Am I in the right one? We maybe should move on to the...
Dr. Mialek in the audience? Audiovisual, do we have the slides? No, we don't have. Okay.
Okay, well, let's maybe move on then to, to hear from Dr. Ganesh Kumar K. Amanaya, effective octopus stabilizer on cardiac output during off-pump coronary artery bypass graft surgery. And I think here comes Dr. Amanaya. I think I got that right.
Yep. Okay.
A very good morning to all. The topic of my research is effect of octopus tissue stabilizer on cardiac output during off-pump coronary artery bypass graft surgery. I have no disclosures to make. The octopus tissue stabilization system facilitates coronary artery bypass surgery, specifically on the beating heart. Octopus tissue stabilizer was first developed by Borst et al. In 1994. Janssen et al. First successfully used octopus tissue stabilizer to perform off-pump coronary artery bypass surgery in humans. The octopus tissue stabilizer has continued to evolve with several design improvements that include lower profile, flexible heads, disposable transparent paddles incorporated into one-piece system which mounts directly on sternal retractor. A suction fixation method helps to expose all sides of heart and may be used through any access point. The octopus tissue stabilizer consists of two suction paddles placed in parallel on either side of the coronary artery. A suction pressure of 300 millimeter mercury effectively immobilizes the target site. The hemodynamic instability that occurs during positioning of the heart and stabilization of coronary targets with interruption of coronary blood flow are important factors limiting the safe performance of op-CAB surgery. The mechanism of hemodynamic instability is a temporary decrease of RV output and as a result, a decrease of left ventricular output. If this unstable situation persists too long without proper correction, circulation will not normalize and grafting will be impossible. A strong and clear communication between the surgeon and anesthetist is crucial in guiding the stabilization. Several studies have been performed noting the changes in hemodynamic parameters during op-CAB using mechanical stabilizers for coronary target stabilization and management of hemodynamic instability. However, the hemodynamic variables measured in most of the studies were either sparse or were measured only once during the procedure without noting the progress of hemodynamic change during coronary artery anastomosis. So significant hemodynamic derangements can occur during off-pump coronary artery bypass graft surgery, which may necessitate conversion to on-pump surgery. We therefore propose to evaluate the alterations in hemodynamic parameters in patients during the course of anastomosis in op-CAB surgery using octopus tissue stabilizer. The methods, 100 consecutive patients undergoing op-CAB surgery were studied. The hemodynamic variables, including cardiac output, heart rate, mean arterial pressure, and central venous pressure were recorded. At baseline, during each coronary artery anastomosis at 2 minutes, at 10 minutes, and after the release of the octopus stabilizer. We used flow track or Vigilio system by Edward Life Sciences to measure the cardiac output. Blood pressure was recorded with invasive femoral arterial line. As you can see, the various coronary anastomotic territories with LAD, obtuse marginal, and PD. The hemodynamic variables were recorded, that is cardiac output, heart rate, mean arterial pressure at 2 minutes, 10 minutes, and after the release of the octopus stabilizer. During the course of target stabilization and anastomosis, adequate fluid management and appropriate positioning of the patient, including Trendelenburg maneuver, were applied as first-line measures as per CVP, cardiac output, or systemic vascular resistance and mean arterial pressure. Inotropes, generally adrenaline or noradrenaline in the lower dose or titrated upwards, were used when hemodynamic instability persisted despite non-pharmacologic means. Emergent conversion to on-pump surgery was done when mean arterial pressure was maintained less than 60 millimeter mercury despite volume loading and inotropes, along with significant ST changes. The results. Cardiac output decreased significantly after target stabilization and during all coronary anastomosis, from the baseline of 5.42 plus minus 1.1 liter per minute at baseline to 4.26 at 2 minutes and 3.92 liters per minute at 10 minutes. The greatest decrease in cardiac output was noted during obtuse marginal, that's the OM branch of left circumflex artery anastomosis, all the way to 3.67 liters at 2 minutes and 3.38 liters at 10 minutes. As you can see, there's almost a 32.2% drop at 2 minutes and 37.6% drop in cardiac output at 10 minutes with significant p-value. This was followed by PD and the least by LAD. The central venous pressure was maintained without any significant change during all coronary anastomosis. Inotropic drugs were required to maintain mean arterial pressure greater than 60 millimeter mercury in 43 patients. The fall in mean arterial pressure necessitating inotropes was most frequent during obtuse marginal artery anastomosis, that is 32 patients. The incidence of bradycardia requiring inotropes was noted to be highest, 11 out of 16 patients during LAD anastomosis. 3 patients required conversion to on-pump surgery, while 4 patients required IRBP support that permitted performance of OPCAP. As you can see, the drop in mean arterial pressure less than 60 millimeter mercury necessitating inotropic support, that's 32 patients for obtuse marginal anastomosis with significant p-value and significant bradycardia requiring inotropic support in LAD territory with, again, significant p-value. Mathison et al. And Kwok et al. In separate studies reported higher incidence of hemodynamic instability during lateral wall anastomosis, which is in line with the present study. Mathison et al. Reported that RV dysfunction induced by direct ventricular compression is the main cause of hemodynamic instability as observed with TE. And he reasoned that displacement and compression of the RV to a greater extent than LV is responsible for hemodynamic alterations when using suction-type stabilizers. The degree of increase in RV wall tension is greater than in LV, and since the RV is more affected by compression compared to LV because the RV has thinner wall and lower pressure, it is easy to be sandwiched between the thicker LV wall and pericardium when the heart is displaced. Coronary occlusion during the anastomosis can have additional effects on the LV function depending on the status of collateral flow. These hemodynamic changes, either secondary to stabilization technique or due to transient ischemia, represent an important diagnostic challenge during OPCAP surgery. Previous studies have used TE or thermodilution PA catheter for the estimation of cardiac output. As hemodynamic derangements during anastomosis is attributable to RV dysfunction, one of the most frequently employed methods to comparatively evaluate RV function during the operation is TE, which can monitor RV as well as LV function and detect myocardial ischemia during OPCAP. However, TE use has limitations during the positioning of the heart for anastomosis, and measuring RV contractility with TE is difficult because of the complex shape of RV. Alternatively, other studies have employed the thermodilution technique, which has high reproducibility. However, the pulmonary artery catheter is a non-specific tool to assess RV function, and most important disadvantage of this catheter is that RV function is that RVEF is a load-dependent variable, and the RV volume is calculated based on RVEF. The change in RVEF reflects the change in RV function, but does not mean the change in intrinsic RV contractility. Another limitation of this catheter is that it does not provide a real-time information regarding changes in RVEF and RV volume. Therefore, the present study is the first study to evaluate the effect of cardiac stabilization on cardiac output in op-cap surgery using a non-invasive monitor, that is a flow track monitor. Yeon-Jo et al. In 2011 and Suhiro et al. In 2017 have reported excellent reliability of flow track or the Vigilio system in the measurement of cardiac output, even in patients with low ejection fraction, and showed reliability at all the time points of measurement with a limit of agreement of just -0.07. Being the least invasive, flow track monitor would be the choice of care in the real-time monitoring of cardiac output in op-cap surgery. The higher incidence of bradycardia during LAD anastomosis can be explained on the basis of LAD being the first in order of anastomosis, apart from placing a mop beneath the LV to lift it anteriorly. The incidence drops with subsequent anastomosis following the revascularization of the anterior and the anterolateral wall. There are certain limitations of this study. It's a small study population of just 100 patients, which was not propensity matched. The diagonal artery was clubbed with LAD, while distal RCA was clubbed with PDA, and no separate recordings were made. Patients with severely impaired LV function, that is with ejection fraction less than 25%, were excluded from the study. Therefore, to conclude, during op-cap surgery using octopus tissue stabilizer for coronary target stabilization, CVP was maintained constantly. However, cardiac output decreased immediately after target stabilization and reduced further during all coronary artery anastomosis and most during obtuse marginal anastomosis. The use of inotropes was most frequent during obtuse marginal anastomosis. The incidence of bradycardia was highest during LAD anastomosis, probably because it's the first anastomosis to be performed. And op-cap surgery is feasible in majority of patients, even with hemodynamic instability, 93% in this study, with appropriate inotropic management or additional IRBP support. Therefore, careful and vigilant monitoring and management of hemodynamic variables during op-cap surgery are of paramount importance to avoid conversion to on-pump surgery. Thank you.
Yeah. Congratulations on a good study. Are there any questions from the audience? Can I ask you? You want to ask it?
I wanted to know, do you open the right pleura completely like Dr. Zambar does?
Yes, we do. Yeah.
Okay. And the other thing is, do you ever use end-tidal CO2 to monitor your heart function?
Not that much, yeah.
The end-tidal CO2 is the first thing to go down before blood pressure and everything.
Okay.
It should stay the same. Dr. Taggart uses it, and I've started to use it as well.
Okay.
Just
thanks for the tip.
Okay.
Thank you so much.
Can I also say that, no, carry on, Federico.
No, a couple of comments. First of all, the marginal, I agree that is the, so there are 2 or 3 tricks. First, you need to stick the heart, because most of the time you create mitral insufficiency sometimes if you don't stick the heart appropriately. Yes. And then the uppers need to go to your right leg initially. If you do that, and I never use a suction. You know, I described the first suction pattern also, I did that, but I always use mechanical. And I have some mechanical prototype that with lateral foot that facilitate that situation. But I agree with you that if you use suction and you compress the suction and you don't stick the heart properly, this is the problem in general.
Right. Okay, thank you. Can I ask you a few questions? Why do you use a femoral arterial line? Why not radial?
we do use radial and femoral in both actually in most of the patients as a routine practice.
Okay, you mentioned you use femoral arterial lines.
But generally the femoral is more reliable because the radial tends to get damped pretty quickly.
Okay. I would also like to say that you said 93% of patients have hemodynamic instability. However, a fall in cardiac output from 5.4...
No, not 93% of those who had could still undergo OPCAP.
Okay. Yeah. I would also like to stress that when you were doing optus marginals, your cardiac outputs came down from 5.4 to 4.2 to 3.8. Yes. That's not actually very bad. A 3.8 cardiac output is quite good, and it's only for 10 minutes or 15 minutes that you need to do an anastomosis. Okay? Anyway, congratulations on a good study. Okay. And can I also remind everybody that we have the World Society of Cardiovascular and Thoracic Surgeons journal now, and I would request all the presenters here today to submit your manuscripts for our journal. And you can submit via the website.
Yes.
Okay?
Yes.
Yeah. Thank
you so much.
Okay. Can I now invite Dr. Yuri Schneider to discuss off-pump coronary artery bypass grafting through left-sided thoracotomy in the treatment of patients with coronary artery disease.
Good morning, Chairperson. Good morning, colleagues. We change speakers because Professor Schneider had a serious family problem, and I tell about our work. Our clinic works 5 years. We are a young hospital, and in 1966, all famous Vasily Kolesov says the surgeons should be armed with no methods of surgical interventions and pick for each patient the one that can provide the best results with least risk. The number of patients with coronary heart disease is increasing annually. Many of them require surgical intervention. In some cases, advanced age, severe myocardial dysfunction, the presence of severe comorbidity, previous heart surgery doesn't allow to perform a complete coronary vascularization, or coronary artery bypass grafting is associated with high operative risk. In our clinic, this operation we used for patient with isolated lesions proximal part of the left anterior descending artery and patient with multivessel lesions. For this patient, this stage of a hybrid intervention. For last 4 years, we make 439 operation. 17% was male. Euroscore 2 was 3.8. 25% patient with diabetes. Some patients was after revascularization. 12% patient was after stenting coronary artery, and 20 patient after CABG. 8 patient after anastomosis left internal mammary artery to LAD, and 12 patients used autovenous graft. In 97% patient we used left internal mammary artery, and 12 patient we used graft autovein. All patients with ordinary comorbidity disease. All patients for last 2 years we used general anesthesia and paravertebral block with solution europine, and all patients, we used 1 lumen intubation tube. In our work, we used 2 rib retractor. First type retractor we used for patients with obesity, and second type retractor we used for patients with normal weight. The length of the skin incision from 5 to 12 centimeters depends on the degree of obesity. Average time harvesting skeletonized mammary artery up to 20 to 55 minutes. For with this patient, 77-year-old woman with coronary heart disease and diabetes, chronic renal failure, with paroxysmal form atrial fibrillation. On cardiogram, we see occlusion of LAD and occlusion right coronary artery. We harvesting skeletonized left mammary artery and anastomized with LAD. And later we stenting right coronary artery. We don't have late results. This is average intraoperative blood loss was 240 milliliters. Postoperative bleeding in 7 cases. Mortality was low, and wound complication to off-pump coronary artery bypass grafting through left side thoracotomy is a surgical method with less injury, short hospitalization time, and fast recovery, which can be used as the isolated lesion of the left anterior descending artery and multivessel as a stage of hybrid intervention. Thank you very much.
Thank you very much for a very lovely study. I have a question for you. What percentage of these patients are of your total CABG population?
4 or 5 years, we perform more than 1,200 CABG.
Okay, thank you. So it's about a third. And how do you decide to submit a patient to the hybrid procedure?
Third part of this patient was, as usually, after acute coronary syndrome.
Okay. But why not full CABG?
The
high risk? You think they were high risk?
This patient with high risk.
Okay. Are there any other questions?
Yes. Congratulations for this fantastic presentation. I just have one thought for you to analyze. Do you sacrifice a minimally invasive surgery for a long-term patency of the grafts? Because you're doing hybrid procedure, so you're putting stents. And, well, I think that stents are not as good as a radial artery or internal mammary artery. Why do you sacrifice that?
We accumulate our experience, and more later we tell about it.
Okay. Can I ask you a question? It's a technical question. What stabilizer do you use?
Medtronic and Makia.
The Octopus or the Nuvo stabilizer?
Octopus.
Octopus. Okay. Any other questions? Okay. Thank you very much. Okay, there are 2 more talks in this session, and they are not related to coronary arteries, but it's very important for us to hear about other topics as well, because that leads to exchange of ideas. Now, the next talk is by Rui Almeida. He's going to talk on education in endovascular surgery. And can I also remind everybody, though it's not mentioned in the printed program, it's present on the website. The talk following this will be by Professor Kalangos on aortic valve repair. Is he in the audience?
Okay. Thank you very much for the organizing committee to invite me to come over here and speak. I feel, like you said, as the ugly duckling, speaking of endovascular surgery in a coronary, and I'm not speaking about stents at all. Don't forget that. So, these are my conflicts of interest. I'm a university professor and a cardiovascular surgeon. I come from Brazil. This is what most of you will know. And I come from a region of Brazil which is in the south part, and it's nearby the Iguaçu Falls. The interventional and structural defects of the heart, they started a long time ago. And as you can see, most of these patients say the congenital heart defects, the cardiac valve disease, the heart failure, and the aortic disease nowadays can be solved by using endovascular surgery. So these are devices for the correction of structural defects of the heart, as most of them you will know, and they've been used for the last 10 to 20 years. But if you look back to 2006, there was this paper published in an interactive journal of cardiovascular surgery, which written by Dietrich from the Arizona group, that said that most of these procedures like patent ductus arteriosus, coarctation, atrial septal defects, and pacemakers, thoracic aortic pathologies, peripheral vascular surgery, and coronary artery bypass grafting have been taken off from the cardiac surgeons into some other interventionists. And this was very, very bad. And the problem was, that there was a competition between specialities, and there were economic barriers on following this part, and that the future could not be brighter for those who were willing to adapt, innovate, or conquer the challenges that were coming. So what are the pathways for endovascular surgery nowadays? Basically, we have the STS and ATS statement that comes up from 2006 that says that to be an endovascular surgeon, you had to complete the ACG MEA thoracic surgery residence and to do 20 patients in 2 years prior to have your credentials. And this has been adopted for most of the time. The qualifications for this have been established over an experience of 10 open thoracic surgical procedures with a minimum of 25 wire catheter placements by that time, the participation in 10 abdominal or 5 thoracic aortic endovascular stent grafting procedures, an experience with large bore femoral sheath cannulation, and experience with retroperitoneal exposure on the procedures of the iliacal arteries. So these were the qualifications. Apart from this, you had to have individual and physician team points. Say, if you're an individual physician, you meet all the stated qualifications and complete a continued medical education program in endovascular stent grafting. And that as a physician team, you cumulatively meet the stated qualifications, and all the team members complete a continued medical education. So this has got to be the same for both, even individual and physician, to be credentialized. With these current guidelines, the vascular procedures, the endovascular procedures went up in numbers for the first, in the last 10 years. And the open surgeries, they came down in reality. And this is what we see in real life. So on this paper published from the STS, they concluded that the endovascular skills can be safely transferred using a vascular surgeon-based training paradigm. So this has been happening for the last years. The guidelines, they only say that the problem is how many cases you should be doing before you get credentialized. So there's 4 medical specialties that are in this zone of comfort of endovascular surgery: the vascular surgeon, the radiologist, the interventional cardiologist, and the cardiovascular surgeons. And all these specialties can do the same thing. but they all have different backgrounds. So from my understanding, as Chaplin said, life is a local matter. Each one of us has to see what's the best for the specialty and what's the best for the surgeon. And these demographic differences have led to different points of view on how general situations seen by each specialty. Which specialty has the most capability to perform this procedure? Are the vascular surgeons, the radiologists, or the cardiac surgeons? And who is entitled to perform this kind of procedure also? So for this point, we have to know that for any type of surgery, and also for endovascular surgery, the physician needs to know the disease, be able to treat the disease with techniques already established, and have a full amount of techniques that can be done for the same patient, and be able to acquire new technical abilities and take care of the patients in the post-op period. And the most important of it all, be able to treat all the complications in these patients. And I think this is the point that the cardiac surgeons can really do it because they're accustomed to treat it by opening surgeries. So for this, and this is the point of my talk, we have to have a formal training program. And this formal training program should have a qualified academic faculty, which is the most important part. A well-designed curriculum including theoretical and practical instructions, training by means of virtual training and live surgeries, and this should be under direct supervision of qualified cardiovascular surgeons, and cases performed as first surgeon. And apart from that, at the end, a valid evaluation program. So these are the means that we do virtual training. Most of these devices are given by the industry, so that's why they're different from one another. And it's important to have adequate training for safe and high-quality performance of the endovascular procedures, not only for the cardiac surgeon, but also for the patient. Sorry. Agarwal, a long time ago in London, has started the virtual reality simulation training for endovascular skills. And he's proved that surgeons with minimal endovascular experience can improve the time taken in contrast usage during short phase training of virtual reality simulation. And apart from that, Kendrick, in a paper published in 2015, the Journal of Surgical Education, which I can assure it's a very nice journal, speaking about endovascular simulation said, and using the Likert criteria, said that on this study, where they were studying about TEVAR, the specific simulated cases can improve both objective and subjective measures of endovascular technical success in all trainees, and that they believe that the endovascular simulation should be considered elective. Agarwal again and his group published nowadays, this year, a very nice paper where they had a stepwise endovascular curriculum training they call Prospect, where they compared 3 groups of trainees, one that had only usage of the simulator, one that had the simulator and the e-learning, and another one that hadn't got anyone. And so what they concluded is that it's a structured stepwise proficiency based on the endovascular curriculum, including e-learning and simulation-based training, should be integrated early into training programs to enhance trainee performance. Back home, we have a program for endovascular surgery, just the TEVA part, which includes course in endovascular surgery, referring training centers organized and supervised by the endovascular department of the Brazilian Society of Cardiovascular Surgery. The hands-on course, participation of the industry and supervision of the department, and meetings in endovascular surgery for case discussion and experience organized at local, regional, and national level with the participation of experts in this area. This is the minimum curriculum that for training centers that include starting from the basic with radiologic and protective fundamentals, hybrid operating rooms, the concepts and geography, endovascular materials, computed tomography, acute aortic dissection, and so on and so on. So that will include everything. This part is for people who are trained already in cardiac surgery and have to be trained in endovascular surgery. We have in Brazil 20 training centers in 10 cities from this vast country. And the basic starts from the basic, really, which you analyze the angiographic catheters, the material type, the manufacturing, the inner diameter and outer diameter of the catheters. And this is really basic, I know that, but most of us that haven't done endovascular surgery do not know how to work in this point. We haven't never, in our past graduation, or post-graduation, had any type of interest in going to the cath lab. So we have to know the ways of the catheter formatter and basically go back to virtual training and do some hours with this case. Virtual training is very impressive, especially not only for the trainees, but also for people who do it and who can do the cases before, the day before, so they can see what are the paths, the best path to go over with the case and lose less time when you do the real case. So this is another part. This is the second part where you learn how to do some of the loops and the curves that are important when doing endovascular surgery. Nowadays, we have an education and training program in the area of endovascular surgery that's consisting of 3 phases. Phase 1, the theoretical courses approved by the endovascular department of the Brazilian Society of Cardiovascular Surgery. These courses contemplate a minimum program, which we talked before, and it's with a total of 100 hours. And then the second part, it's the specialized training offered by in the facilities of the Brazilian headquarters or at the universities, where that means that they use the virtual simulators or any other type of training, non-clinical, including experimental surgery, with a total of 250 hours. And the third part is a fellowship in training centers previously approved by the Brazilian Society with a total of 500 hours. In this phase, the complete revision of theoretical issues presented as well as clinical meetings, discussions will take place. Apart from that, now we had, between the two societies, the Interventional Cardiology Society and the Brazilian Society of Cardiovascular Surgery. And they all been referred by the Brazilian Medical Association, which we have recommendations for doing TAVI. So you have to have the endovascular training before, and this is the second part where you have theoretical sessions at least for 24 hours in courses recognized by both societies, sessions in simulators with at least 2 hours, and participation as an observer at least 2 cases in centers already recognized as training centers. And here, there's a big difference between the transfemoral procedures and other ones. In the transfemoral procedure, the interventional cardiologist only has to do 5 procedures in the last 2 years, but the cardiovascular surgeon has to do 10 procedures in the last 10 years. And this difference is because most of the people haven't got the ability as the interventional cardiologists have. On the other side, the procedures performed by alternative accesses like transapical or transaortic approach, the interventional cardiologist is not allowed to do it, but it's only reserved for the cardiovascular surgeons with a 5 procedure under supervision for the first times. Let me point out that I think that the most important part in training people and educating people is the mentorship. And you have to have good mentors that will be role models who can teach and coach at the same time, advise, support, be friendly, intellectually honest, and this is important, a competent communicator, be a supervisor, and give you feedback. And I think this is the most important part of how to start an education program in endovascular surgery. So the lessons to take home that I bring it to you is training is nowadays the most important subject in cardiovascular and endovascular surgery. We should attempt to unify educational and training programs in most of national societies. We should create programs to teach cardiovascular surgeons to become mentors. And the World Society of Cardiothoracic Surgery has to play this role in organizing the educational programs. And as we said, bridging the gaps that we have. So, quoting Winston Churchill, we make a living by what we get, but we make a life by what we give. Thank you very much.
Thank you very much, Professor Almeida, for a beautiful overview of a very important topic. I do have one question. Do you think there is a role for proctorship in endovascular training? In other words, students have been through a wonderful program, they've done them, but then they go back to their own home turf. Would it be advisable to have one of their mentors come with them for the first few cases to just make sure any pitfalls don't happen so they have a good start?
Oh, I'm sure there is. The proctors, it depends on which proctors we're speaking about. If the industry proctors or the proctors from the societies, there's a big difference between those ones. Most of the proctors from the industry will have a bias of choosing some of the prostheses. Instead, if you have someone from the national society or an expertise in that field, he can help you do what's the best. But sure, the proctors are important. We have a problem in proctorship over in Brazil because our General Medical Council is not united, it's by provinces, and so you cannot work if you haven't got your general medical of the province, you cannot work there. So most of these things are done under the cloth.
Under the radar.
Yeah, sure.
No, I think both are important, actually. I think you need industry and you need surgeons. But thank you. Thank you. Any other questions?
Thank you, Rui.
Thank you.
Yeah. Can I now ask Professor Kalangos to give a talk on repair of the aortic valve in children?
Good morning, everybody. Thank you very much, Dr. Zanvar. The title of my presentation is the aortic valve repair in pediatric population is, you know, repair is better than replacement. It's obvious. But unfortunately, in aortic valve repair, as in mitral valve repair, we have also some limits. And I would like to present how far can we go. The aortic valve, as you know, is a geometric unit made by different anatomic structures: the leaflets, the sinotubular junction, the ventricular aortic junction, the sinuses of Valsalva, the commissures, and the interleaflet triangles. And between all these structures, there is a geometric harmony and integrity, as you see here. For example, the ventricular aortic junction is 15% bigger than the sinotubular junction, and the height of the sinus of Valsalva is 80% of the diameter of the sinotubular junction. We know very well, because all this mechanism inducing aortic dysfunction, aortic valve dysfunction, are very well defined. And we know now that the majority of this mechanism are repairable. But the most important question, if you would like really to do a good repair with a good result in mid and long term, you have to get a good quality of leaflets tissue, and the evolution of the underlying aortic valve pathology is also very important. You have, you know, to know clearly these 2 points. And the aortic valve repair is not only the repair of the leaflets, it's the repair of all the structures making up the aortic valve. It means is the repair of the aortic root. Now, regarding the mechanism, we have the decreased leaflet mobility due usually to the retraction of the cusp, the prolapse due usually to the free edge elongation, and then you have some association between this mechanism, retraction plus prolapse, or dilation of 1 or 2 junction. Now, how to increase mobility? Again, you know, there are very old techniques. The commissurotomy is one of them. the shaving of the leaflets in order to increase the mobility. Then in 1999, I published the first case of tracheospecialization of the aortic valve in the context of a bicuspid valve in the Journal of Thoracic and Cardiovascular Surgery. And since then, they started systematically doing this surgery, the other teams. As you see here, for example, this team coming from Melbourne, from Brizard, they started systematically using the tracheospecialization in bicuspid leaflets, as well as you see here, removing all this fibrous tissue, creating a new commissure in order to increase the mobility between these two leaflets by using pericardial patches, or removing the raphe and putting a triangular piece of pericardial patch. And with all these combinations, you can really increase or improve the mobility of the bicuspid aortic valve. Now, the second mechanism is the prolapse related to the elongation of the free edge without the retraction, because if you have retraction is another sort of technique. For the free edge shortening, the oldest technique is described by Trassler. As you see here, first with the suspension flatter stitch, you determine the excess length of the free edge of the cusp, and then you placate the excess length at the site of the commissure with a plate reinforced suture material. The other one is the free edge plication with a running Gore-Tex suture material. And then you have the triangular resection or plication, and if you would like to suspend the free edge by 1 millimeter, you have to plicate or resect at least 3 millimeters. You can use this triangular resection or plication even for bicuspid valve. As you see here on the side, you have the resection of the raphe, because usually you have a free edge elongation in the leaflet where you have the raphe, and you can resect it and close with interrupted sutures, or you can determine the excess length and plicate this cusp at the level of the raphe. Or you can use these two techniques, as you see here, the triangular resection, if you have really free edge elongation of both leaflets, triangular resection and plication, resection and plication. Now, the other mechanism is how to correct the aortic insufficiency due to cusp prolapse with retraction or pure cusp retraction. And here, again, the technique is very well defined, and I contributed also with my team a lot, is the cusp extension. The best, there is no ideal tissue substitute, unfortunately. We use the autologous pericardium. I don't want to enter into the details which one is superior to which one. I started using, because I am coming from the school of Carpentier, I started using the short-term glutaraldehyde treated pericardium, and then I shifted to the fresh autologous pericardium in children. And then I use CardioFix. CardioFix, there is no glutaraldehyde fixation, is fixed with light, because as you know, the glutaraldehyde molecule is a dangerous molecule because there is free aldehyde radicals. And unfortunately, these aldehyde radicals, usually they cap the circulating calcium, and they start the calcification process. And for that reason, you know, there is no ideal, unfortunately, tissue for that. And the most important regarding the technical part is because usually when you have, especially in the rheumatic process, when you have some degree of retraction, this degree of retraction is not similar at the level of each of the cusps, of the three cusps. And for that reason, you have an asymmetrical aortic valve. And for that reason, the target with the cusp extension is to add the necessary amount of pericardial tissue in order to render this cusps symmetrical. You can use also this cusp extension technique for bicuspid valves as well. Now, regarding the early and long-term results, as you see here, we did two publications. The first one in '99 in the Journal of Thoracic and Cardiovascular Surgery, and then we reviewed the long-term results with the cusp extension technique in 2010 published. And as you see here, the event-free survival at 16 years is 70%. Is good, especially in the pediatric population, where there is no a lot of alternative other techniques. And as you see here, we got similar results between the fresh autologous pericardium and CardioFix, but in some cases we tried also the glutaraldehyde treated pericardium, bovine pericardium. As you see here, the results are not so good. And here you see also a CardioFix. This case, unfortunately, I reoperated 5 years after initial surgery. As you see here, it was impressive for me because there was no calcification at the level of this CardioFix tissue, light-treated tissue. It's bovine pericardium. The recurrent aortic insufficiency was due to the recurrent dilation of the sinotubular junction. And there was, as you see here, creating the space and lack of coaptation between this expanded leaflets. And for that reason, I decided to replace with a homograft because it was a female young patient coming from an African country. Now, the other mechanism inducing aortic insufficiency is the dilation. Usually is an associated dilation of the ventricular aortic junction. Again, there is two old techniques. The first one was described by Carpentier, the circular annuloplasty, and the second one, the cabral-plasty, as you see here. And with this plate reinforced suture at the commissural level, you reduce the subcommissural area and you improve the coaptation between the three cusps. And then, unfortunately, these two techniques have also some limitations, and for that reason, as in the mitral valve repair surgery, some surgeons started developing annuloplasty, different annuloplasty techniques using some synthetic material, as here Lanzac conceived and developed this band, which is a circular band passing beneath the coronary arteries, both ostia. And there is also the other technique described by Schaeffer's, which is a suture material around the ventricular aortic junction in order to decrease, normalize the diameter of the ventricular aortic junction. The other one is the band reduction, because usually the dilation of the ventricular aortic junction is at the level of the non-coronary annular portion, and really, if you would like to normalize this part of the aortic annulus, you can use this kind of band, and with your stitches, you can reduce and normalize the ventricular aortic junction by reducing, especially the non-coronary part of the annulus. And the other one is how to correct the aortic insufficiency due to aortic root and descending aortic dilation, because you have a dilation of the sinotubular junction in these cases, and creating usually this kind of central leak. And here the two techniques are very well described by Tyrone David and by Magdi Yacoub. As you see here, this one is the technique of Tyrone David, and this one is the technique developed by Magdi Yacoub. But if really the only problem is if it's not the dilation of the sinotubular junction, and there is also some free H elongation, some prolapse contributing to the aortic insufficiency, you have also to associate to combine to your aortic remodeling the free H shortening, one of the free H shortening techniques. Now, I will show you some, I will say, crucial papers published, especially in aortic valve repair in children. The first question, which was addressed by Schaeffer's, was if really the techniques affect stability of the aortic valve repair. As you see here, between these three techniques which were taken into account, triangular resection, pericardial cusp extension, pericardial patch and plication, as you see here, the freedom from reoperation was not affected by these techniques, as well as the freedom from aortic insufficiency, grade 2 or more. Again, these techniques don't affect the freedom from aortic insufficiency. Again, you know, the fact that the aortic valve is tricuspid or bicuspid doesn't affect the stability of the aortic valve repair you perform. Again, a very good paper coming out from Kader, and here clearly he showed that the type of aortic valve dysfunction doesn't affect neither the survival nor the reintervention-free survival. Again, another good paper from De La Zarda. Here, the cusp extension technique, as you see here, has bigger early reop in the congenital aortic valve dysfunction than the acquired one, which is the rheumatic pathology. As you see here, the early reoperation rate in the congenital group is 10.5%, and in the rheumatic group was 4.6%. Again, a very good paper published by the team of Melbourne, tricuspidalization versus ROS. Why, you know, they wanted to insist on aortic valve repair, because unfortunately in newborns, ROS surgery has a bigger mortality rate, and for that reason, you know, they wanted to use aortic valve repair as a bridge to a late aortic valve replacement or to a late ROS surgery. And then they compare these two techniques. As you see here, the freedom from reoperation at 36 months is 100% for ROS and 90% for repair with tricuspidalization of the bicuspid aortic valves. And there is no statistical difference. Again, regarding also the freedom from reoperation or more than moderate degree aortic insufficiency, again at 36 months, is 90% for ROS and 75% for aortic valve repair using the tricuspidalization technique. And again, you know, there is no statistical difference. It means that if you don't want to take this additional risk and doing a ROS operation, especially in a newborn, you can use this tracheospecialization with cusp extension as an alternative, as a bridge operation to a late ROS or aortic valve replacement. Again, as I told you, the aortic valve repair unfortunately has some limitations. The limitation is that, unfortunately, in some complex cases, what you do is not durable. And for that reason, again, with this publication, Tweedle clearly showed that it's better to replace than to do a complex repair, and which will fail in short term. As you see here, the complex repair in long term has unfortunately very bad results compared to the replacement. Now, in conclusion, we can say that the advantages of aortic valve repair over replacement are obvious, especially in this pediatric population. You avoid the anticoagulation, the risk of endocarditis is lower, and you allow children as much time as possible for the annulus to grow, which will later allow for the replacement of the aortic valve by a larger valvular prosthesis. Again, aortic valve repair is also very clear that is a standardized and reproducible with stable long-term results, not in the complex group, in the restricted pathology of the aortic valve dysfunction, in a definite subset of patients. And despite all these technical refinements, the outcome of the material use and evolution of the valvular pathology influence the long-term stability of the aortic valve repair. And then don't forget the surgeon's expertise is also one of the most important factors influencing the mid-term and long-term stability of the results. Thank you very much.
Thank you, Professor Kalangos. Can I just mention, since this is the coronary session, Professor Kalangos has, I wanted to introduce him earlier. Professor Kalangos does a lot of charity work via his Kalangos Foundation and does a lot of operations in Africa. At present, he operates in Turkey and Greece and has also been appointed as a professor in China. Is that correct?
Yes.
And he'll be operating in China as well.
Now we have a new humanitarian center in Yunchuan, which is one of the emerging provinces of China. And we set up the new humanitarian center of Kalangos Foundation over there.
Okay. So, yeah, any questions from the audience? Yeah.
What do you think about Ozaki procedure for children?
Yeah, I didn't mention the Ozaki procedure because it's not repair, it's replacement, because you remove all the cusp tissue. For me, it's a good operation, but unfortunately there is no long-term results. As I mentioned at the beginning of my presentation, really, if you would like to do aortic valve repair, you have also to think about the durability of the repair. The problem is, what will be the fate of this autologous pericardium treated by glutaraldehyd? You know, I was involved in the basic research projects of Professor Carpentier because I have been working with him for many years. And even, you know, with short-term glutaraldehyd-treated patches, sometimes, you know, in some cases, I don't know what is the mechanism because we don't know exactly what are the factors influencing the calcification process. Especially, we know very well that the metabolism of the calcium metabolism in children is very accelerated. And there is many factors influencing this, this mechanism, the calcification mechanism. And for that reason, you know, I would like to see the results after 15 years, after 16 years of the Ozaki procedure. But what is good with the Ozaki procedure is in the cusp extension technique, you increase the coaptation surface. You are over than 10 millimeters, which is good. Probably, you know, okay, it will a little bit compensate the problems related to the fate of the pericardial tissue by the fact that you increase the coaptation surface by the Ozaki procedure. And for that reason, probably, despite, you know, some calcification in these patches, you know, there will be some leaks later on. I don't know, but we have to see the results after 15, after 20 years.
And what do you think about...
But if you cannot repair, on the other hand, I have to tell, because I'm not against Ozaki procedure, because I'm involved in the cusp extension and is in the same ideology. I believe if you don't have the possibility to repair, especially in some rheumatic pathology, it's better, to do in a child the Ozaki procedure. The other limitation of the Ozaki procedure, especially in young children, is the fact that the cusps will not grow up according to the general growth of the child. It will be, one of the other problems of the Ozaki in very young children.
And what do you think about the modern materials instead the autological pericard, the modern materials?
Yeah,
what
now
do you think about?
I started using. I used the CardioFix, but unfortunately, Carbomedics stopped its manufacturing, and then I utilize the Core Matrix, and now there is a new patch. I have forgotten the name, but I'm also utilizing coming from South Africa, which is a good one. But again, some of my colleagues started publishing early calcification, even with these patches in which there is no glutaraldehyde fixation. Very difficult. And sometimes, you see a child, after 10 years, 15 years, no calcification, even with a glutaraldehyde fixation patch. And then in another child, with a short-term autologous pericardium, you have a very early, what I had, and for a reason, I shifted from the short-term glutaraldehyde autologous pericardium to the fresh one. With the fresh one, there is no calcification, but unfortunately, there is shrinkage.
Okay, any other questions from the audience? We had one question from there. The surgeon behind you. No. Yes, Federico?
Yeah. Your experience with Core Matrix?
Core Matrix, yes. Core Matrix, unfortunately, sometimes, you have an overproduction of the fibrous tissue covering the core matrix. And again, you don't know why.
Why? Because they attract the stem cells.
Yeah, but in some cases, the mobility of the expanded aortic cusp are very good with the core matrix, but in some cases, they become rigid. And when I reoperated, I was astonished, really.
Yeah, okay.
But no calcification, again.
No.
Okay.
Thank you.
Teresa, do you have a question?
Yes, Professor Kalangos, thank you for this very elegant presentation.
Thank you.
I am curious, how is it to repair a pediatric aortic valve compared to an adult? Are their tissues more resilient, more forgiving, or do the repairs have accelerated scar formation because of their rapid growth rate compared to an adult?
Yeah, especially, okay. In adult population, we have also to define the subset of patient which really can benefit from the aortic valve repair. Because on the other hand, we have also now a very good biological prosthesis treated with this new anti-calcification treatments, adverse Medtronic, the anti-oleic acids, and so on, the thermodilution techniques. And for that reason, for example, a young lady for me is a very good candidate for aortic valve repair. Again, the Ross procedure, because I had also in my series a lot of adult cases, and when I compare, with the replacement group, there is more reoperation rate in this group. It's very clear. Is very clear. Okay, if it's a prolapse due to the free H elongation, it's true that the results are better than the other. But if the leaflet tissue is affected by the underlying process, and then unfortunately it's a evolving process. It will not, it will not stop. With the repair, you correct the dysfunction. You don't ameliorate, you don't improve, you don't eliminate the tissue problem. And for that reason, it's better, for example, I had also young patients in whom I did raw surgery in these patients. For example, recently I had, a young guy coming from Ukraine. He was an athlete doing excessive sport, and I did ROS procedure. Again, I know that ROS procedure in adult population has also some limitation. Is not the ideal approach, surgical approach, but in a definite subset of patients, I believe even ROS surgery is better than, to repair and after, 10 years to reoperate on the patient.
I see. Well, thank you very much.
Yeah, thank you.
Okay, I have one question. Is there any questions from the audience? I have one question. Now, this is not related, Professor Kalangos, to aortic valve repairs, but since you do a lot of pediatric operations, the incidence of reoperations is quite high in the pediatric population. So are there any special techniques you use when you close the chest to make life easy for you or for the surgeon who's going to do the repeat operation?
Yeah, it's a very good question. But now, I started doing systematically, and it will be published. We started doing systematically CT scan, thoracic and abdominal CT scan or MRI in children in case of reoperation. Because what is the advantage? First, with the scan with the MRI, you see the relationship between the right ventricle and the sternum. This one is very important to see. The second one, in these cases when you have the impression that the right ventricle is completely in contact with the mediastinal surface of the sternum, is better, to do femoral cannulation. It's a protocol in my center. Yeah. And is also very important to see the abdominal aorta, the iliac arteries, the femoral arteries. Don't forget that an important amount of this number of these children, they were in the past catheterized, and sometimes, they have stenosis. And it's really very dangerous without investigating the arteries, the femoral, the iliac arteries, go and put a cannula. You can create dissection, even, you can create major vascular complications. And for that reason, if you would like to avoid this kind of complication, it's better, to do a thoraco-abdominal CT scan or MRI. Yeah. To investigate the relationship between the right ventricle and the sternum, and on the other hand, the arterial and the venous axis.
My question is, during the first operation, do you do something special
during
to prevent?
During the first operation, again, is part of my protocol. I close the pericardium. You will tell me, when you have you do some tetralogy cases with infundibular or transannular patches or with some valvular conduits, it's not possible to close. This one is right. And then I use Gore-Tex patches in these cases in order to protect the right ventricle and especially the valvular conduits for the second operation. But again, I am receiving a lot of cases coming from the other centers, and unfortunately there is no systematic pericardial closure in these cases. No protection because it's expensive. A Gore-Tex patch has also a certain price. I can understand, and unfortunately now with the economic crisis worldwide, we have more economic limitations, it's true. In the past, I use also, and I publish in the Journal of Thoracic and Cardiovascular Surgery, because in Geneva, one of my basic research interests was the use of biodegradable materials in the cardiovascular domain. And then, I utilized some biodegradable patches to close the pericardium. And unfortunately, again, in some cases, I was disappointed because there was an excessive fibrous tissue development and stuck on the anterior surface of the right ventricle. Again, you know, I judged that it was risky. For that reason, I shifted to the Gore-Tex patches. Again, with the Gore-Tex patches, I had also some cases in which the Gore-Tex probably is related to the degree of inflammatory reaction induced just after surgery, was completely stuck on the ventricular anterior surface of the right ventricle. And for that reason, again, you know, there is also some risks. You cannot tell, you know, 100% it protects. No, sometimes, you know, it can also create some problems. And then, you know, it's a strange material, Gore-Tex, you know, it's a foreign body, and it can even increase the risk of mediastinitis.
Okay, thank you. Any other questions from the audience? Okay, thank you, Professor Kalangas.
Thank you very much.
Can we all give a big round of applause to all the speakers here today? That was an excellent session in coronary surgery. It's coffee break now, and can I please ask all of you to assemble here at 11 o'clock sharp? The next session will start at 11.